So I love talking about this kind of stuff. And we're going to talk about two problems, right? Rotator cuff problems and shoulder arthritis. And you think, well, that's not very much, right? But 30 minutes from now, you're going to realize there's tons of meat on this bone. Yeah, right, exactly. So you can't start with anything but anatomy. The shoulder is a pretty complex thing. There's 3 bones that make it up the shoulder. The first one is the scapula, or the shoulder blade. I want to call your attention to this thing called the glenoid. It's this sort of shallow dinner cup on the outside part of the shoulder blade. And all these things we'll sort of come back to and we'll touch on, and you'll see the relevance of them all. And the second bone is the humerus, or the arm bone. And again, call our attention up here. That rounded top part is the ball, or the humeral head. So the ball and the cup make up the shoulder joint mostly. And again, I want to point your attention to here, these little knuckles of bone on the outside part of the top of the arm bone called the tuberosities. That's where the rotator cuff muscles and tendons plug right into. Okay? We'll talk about the tuberosities quite a bit. And the last bone is this clavicle, or the collarbone. It's a long strut that comes off the chest, right? Believe it or not, it's the only bony connection from the arm to your body, right? And it does so through the acromioclavicular joint. Honest to God, I can't say that more than once. So if I say it again, I'm going to just call it the AC joint. And it meets the acromion, this little expansion that really comes off the back of the shoulder blade. All right? So with that as some basic introductory information, let's dive right into the rotator cuff. Now, the question that I get most often in the office is the rotator cuff a muscle or a tendon? And the answer is yeah, it's both, right? Because what you got to understand is muscles are they're kind of like orthopedic surgeons. They really only do one thing well, right? And in this case, the muscle is good at pulling, good at contracting, right? It's not good at connecting to bone. So these rotator cuff muscles and tendons do what all muscles do. They start at one spot, they go a certain direction, and then they blend into this tendinous structure. And it's the tendon, in this case the tendon, this indistinguishable cuff of tendon tissue that inserts into the bone onto those tuberosities all along the top of the arm bone, the humerus. Okay? Now there's 4 of them. There's 2 on the back. There's this big one in the front. And then there's the supraspinatus on the top. And I call it the supraspinatus because I love Latin. And also it's because that's where most rotator cuff problems start. Not all, but most. Okay? Rotator cuff problems are very common. And more often than not, they evolve over time for a combination of factors all coming together into one. Okay? There's the most common factors. Number 1, it's an overuse problem, a tendinitis problem, right? So when we're doing our thing throughout our day, we're working out, we're doing stuff around the house, or we're doing stuff at your job, you're using your arms and your legs, right, and your muscles and your tendons and your bones, they accumulate all these little micro damages, right? And during rest periods, mostly at night, that micro damage gets healed. So you're good the next day. Now, either if you do too much or if you don't rest enough, this micro damage accumulates and you get real damage, you get tendinitis. And so that's the common story on all these tendinitis problems that happen throughout the body, right? The elbow, the shoulder, the knee. And so it's true here in rotator cuff problems. Now, making this tendinitis overuse problem worse, there's an area of low blood flow right there. Why? I have no idea. That's a philosophical question, right? So what that means is, the body to heal, it needs blood because it brings in nutrients and it removes waste products, right? So with that area of low blood flow, it's hard for the body to marshal that healing response. So that tendinitis problem is a little bit worse right there. Okay? We also know it's an age factor. Unfortunately, as we get older, rotator cuff problems are a little bit more common. Not to suggest that rotator cuff tears and problems can't happen in 20-year-olds, but they're often in 50s, 60s, and 70s, right? And the final most common factor is a mechanical irritation, right? You hear this, who is here have heard of the bone spur, this magical bone spur? Right, exactly. Does anybody have any idea what that means? Or what like the relevance? Probably not. right? Because I say it all the time. You got a bone spur, and I walk away, right? I don't explain it. So when you move your arm, let me back up a second. So let's look at the supraspinatus, right? That one on the top. It starts there, and it goes that way. If you look here, it's there. And as it goes that way, it goes underneath that bony acromial arch, right? So that when you move your arm, that tendon is supposed to glide under that arch. So say if you have a bone spur hanging down, instead of gliding, it rubs. And over time, it wears a hole in your tendon, kind of like the way you wear a hole in your leather dress shoes. So that's the relevance of the bone spur, the mythical bone spur. Not mythical, it's real. All right, so as a result of all these things, rotator cuff problems start and they evolve. Oh, by the way, if you're queasy, I'm going to show some intraoperative photos. There's nothing gross. Don't turn away because I want you to pay attention, but like maybe peek through your fingers or something like that. Okay, so that's how it starts. Right, this is tendinitis. So normal tendon is smooth and glistening. It's like all the fibers are going all the same direction. It looks normal. This is anything but, right? It's disorganized. There's no glisten to it. It almost looks like it needs a shave. Right, so that's tendinitis. Now, if you cut this tendon in cross-section, it's got a certain thickness, about 5 or 6 millimeters. And if that area of tendinitis involves 2, 3, 4 millimeters of that 5 millimeter thickness, you could call that a partial thickness rotator cuff tendon tear. All right? So now this is evolved in an abnormal biomechanical environment. And unless something comes along to alter this environment, it's a good chance that it's going to continue. And it can continue such that you actually wear a small but full thickness rotator cuff tendon tear right in the middle of your tendon, and that's what that looks like. Okay, so we're looking down on the rotator cuff tendon. That's the tuberosity. That's the area of bone to which the tendon should be attached. And that's tendon edge. We should not be able to see that bone. We should not be able to put that instrument between the tendon and the bone. Okay? So that's a small but full thickness rotator cuff tendon tear. Same exact story. This tendon tear isn't huge, but it developed in an abnormal mechanical environment, and unless something comes along and changes that, good chance it's going to continue. And you've got a good chance you're going to develop a moderate to large size rotator cuff tendon tear that looks like that. Okay? So remember the last picture, we saw this little tiny bit of the tuberosity. Now we see the entire tuberosity, right? The tendon edge is there, right? It used to be there. And it's grown. The tendon tear has grown in that dimension, that dimension. And that tendon edge, right, used to be there, is continue to march further and further from where it belongs. Now, what we're not seeing on this arthroscopic picture, which you could see on an MRI, is the muscle belly, which is attached to that tendon, is shrinking. It's atrophying, right? Because it's no longer connected. Okay? Now, you could change the biomechanical environment of this tendon. But the real problem of a tendon tear this size, it's biomechanically significant. Dun, dun, dun. Right? What do I mean by that? When you're sitting here at rest, your muscles are generating force, right? That's muscle tone. We all work out so we have better muscle tone, right? But when you move your arm, the muscles generate more force, and all that force in the intact state is borne by the tendon. But when it's torn, that tendon is not seeing any force. All those forces get concentrated right there, right? That little spot weld in the front, and there's another little spot weld in the back. And the tissue just wasn't designed to withstand that kind of force, right? And it's going to continue to progress in that dimension, and it's going to go around the horn, and this tendon edge is going to continue to march further and further from its home, and that muscle is going to continue to shrink until you get a massive or irreparable rotator cuff tendon tear that looks like that. Okay? We can't even see the entire tuberosity on the frame of the picture. We see a wonderful view of the ball and of the cup. That's tendon edge, right? There's no way you're getting that tendon edge all the way over there. At least, you might be able to do that. You might be able to technically do it, but it ain't going to stay there long enough to heal. Okay? So this is a massive or irreparable rotator cuff tendon tear. And when it gets this big, it changes the function of the shoulder so much that you get a special kind of arthritis called rotator cuff tear arthropathy. And so there's significant arthritis here. The center of the ball is way elevated than the center of the cup. This person hurts like the dickens in their shoulder. When you ask them to raise their arm, they do this, right? So this is a whole other talk. I love talking about this problem too. But the only real solution to this problem is something called a reverse total shoulder arthroplasty, which is a great surgery to do, tons of fun, right? It helps people. But no, it's really just a cautionary tale, okay? Because what we've done here is we've established this spectrum of disease, right? So if you do end up getting rotator cuff problems, you want to catch it here. Here is okay. Here's no bueno, right? We want to stop it before it gets to that point. All right? So, say you have rotator cuff problems. How are we going to treat those rotator cuff problems? And the good news with rotator cuff problems is that 9 out of 10 patients get better without surgery. 9 out of 10 patients that walk into my office never end up seeing the inside of my operating room. Okay? And how we start with is with a brief period of activity modification. So what we want to do is find those activities that are bothering your shoulder, take a brief period of time away from those activities. Once we get the shoulder feeling better, we can start reintroducing those things, okay? Now, it's usually lifting overhead, reaching out, swimming, lifting weights like push-ups, bench presses, those kinds of things. And of course, there's the orthopedic golden rule. The orthopedic golden rule is if it hurts, don't do it, right? It's common sense. That's why I can be an orthopedic surgeon. All right, so what else do we do? Tylenol, it's a wonderful pain reliever as long as you have a normal liver. Non-steroidal anti-inflammatories like ibuprofen, Advil, naproxen, great pain reliever as long as you have a normal stomach and normal kidneys. Sometimes people say maybe you should take these around the clock, absent pain, because it's an anti-inflammatory. In my personal opinion, in the rotator cuff population, this doesn't work that well. So I don't necessarily, I'm not a huge pill pusher in the first place. But definitely not for this problem. Take this as a pain reliever. Cortisone. Cortisone is a useful adjunct to this problem. In and of itself, it's only going to provide temporary relief. Cortisone is an anti-inflammatory, right? If you deliver that anti-inflammatory, bathe that rotator cuff in its effect, it's going to feel better. But like I said, if you don't do something else, the anti-inflammatory is going to wear off and your pain's going to come back. Now, the keystone to all of this other stuff is rotator cuff strengthening. This here affects that biomechanical change that I kept alluding to. Okay? You can do this at home, right? But it's better if you come to therapy, right? This is just not a shameless plug. I don't have a financial relationship here, right? But this works better when you go into physical therapy. And let's face it, it's not a get-out-of-jail-free card, right? You're going to do the exercises here, but they're also going to tell you got to go home and do the exercises, right? So it's really not home exercises or physical therapy. It's both. So what it does, in brief, is that if there's a small tear or some tendonitis, it gets the remainder of the cuff working better, and it changes the function of the cuff so that maybe it used to rub on that bone spur, and now it clears underneath that bone spur. If we want to talk about that in the question and answer period, I love that discussion, but it kind of gets down into the weeds a little bit. So, like I said, 9 out of 10 people, this is what they get. 9 out of 10 people, their shoulder pain gets better, they go away happy campers. Now, if you're the 1 out of 10, and or if you have a biomechanically significant rotator cuff tendon tear, you're going to go to the operating room, right? And the key, there's lots of keys in the operating room. The key, though, if you've got a tendon tear that looks like this, is you want to make it look like that, right? And you want to do it arthroscopically, right? We're going to use tiny little incisions. We're not going to make big incisions and create bunches of scar ball, right? It's a minimally invasive approach so that people get better faster. The key to that process is, besides the surgeon, their know-how, is this thing. This is called a suture anchor. And there's lots of different designs and there's lots of different materials, and none of it matters because they all work. I chose these two because they're prototypical. There's some sort of body to the suture anchor. Out of that anchor comes these threads or sutures. And there's some sort of way to keep that body in the bone, because you're going to put this thing into that tuberosity. You're going to put it into the part of the bone that you want the tendon to eventually heal into. Okay? In this case, there's threads, kind of like a wood screw. So, We got our tendon tear. That's the tuberosities. There's the ball out there. We've got 1, 2, 3 anchors into the tuberosities. We've passed our suture through the tendon. Like if I could pan my camera back, you'd see the suture threads up there. And I would tie a knot. And as I tighten that knot down, remember the suture's connected to that body. So that knot is going to approach the body of the suture anchor. And as it does so, it strangles or kind of squishes the tendon down onto the bone and holds it there until Mother Nature heals it there. Okay? So that's a real quick and dirty on how you do an arthroscopic rotator cuff repair. All right. Now let's switch gears a little bit and talk about shoulder arthritis. And when we're talking about shoulder arthritis, we're talking about the glenohumeral joint. I didn't tell you this yet. All these terms are meant to sound fancy so I sound smart so I can justify my bill. That's true of all doctors, by the way, right? So when you look at this word glenohumeral joint, it's basically where the glenoid meets the humeral head, right? And the glenoid's the cup and the humeral head's the ball. I can't just call it the upper arm ball and socket joint because that sounds stupid, right? So that's a normal glenohumeral joint x-ray. So we got a ball and the cup. And you see there's this little clear space between the two. All right? That represents the cartilage liner. There's a cartilage liner on both the ball and on the cup. And you don't see it on x-ray because cartilage is soft tissue. Okay? Now this cartilage is the bearing surface of the joint. It's wonderful stuff. Cartilage, rubbing on cartilage is almost friction-free. It's like spider web. We can't make this stuff. Right? Only nature does this. We don't know how or why, but it's just wonderful, beautiful stuff. And I analogize cartilage to the tread on one's tires. Right? And when you've got nice, juicy tread on your tires, your car runs great. But unfortunately, over time, you can wear out the tread on one's tires. And in this case, when you wear away the cartilage, you notice that on an x-ray because the bones get closer together. That clear space goes away. In addition, you develop these big bone spurs, and then you start to see deformity of the ball. It's no longer this nice round ball. It's sort of this squished in ball. And if you get another view, you no longer have a nice shallow dinner plate. You've got this weird double bubble thing to the cup. Right? So this is a pretty standard looking shoulder arthritis, a case of shoulder arthritis. Loss of clear space because the cartilage has been worn away. And you secondarily develop bone spurs and deformities on both the ball and the cup side. So that's what arthritis is. How do we treat it? Now, if you've been paying attention, you know this is the same exact slide I showed you 5 minutes ago for rotator cuff problems, right? It's because I got lazy and I was tired and I was like, I'm going to use the same exact slide. But the truth of the matter is it's the same modalities, but it's a different disease, and we're going to focus on different things. And the biggest difference versus rotator cuff problems, which we can either make better or operate on and make better, we can't get cartilage to regrow. It's like a spider web, right? We don't know how to do it. So we can't stop arthritis. We can't heal arthritis. We can maybe slow it down. We can make the pain better for a period of time. We can maintain function, but it's a progressive degenerative condition. So the focus is going to be a little bit different. We're going to talk about activity modifications, right? And it's likely to be activity modifications that are going to be relatively permanent. And so hopefully we're going to focus on little things that we can do with your environment to affect activity modification that you don't find intolerable. For example, if it hurts to reach your plates, and they're the plates that you use every day, you bring them down to a lower level. If you're sitting at your desk, and there's a form over here that you grab all the time, and it hurts to reach out, you bring the form over here. I mean, it's just simple, right? And it works. This can be a significant benefit. Now, I have to admit, the other thing about activity modification is that over time, 5, 10, 15 years, the things that you have to do can become intolerable, right? The activity modifications that you have to employ start to limit the quality of life. And oftentimes people come back and say, you know what, I used to be able to tolerate this, but this is just bumming me out. And so this sometimes is the reason why we opt for surgical intervention. Tylenol and anti-inflammatories are great pain relievers. More patients here with arthritis take this around the clock. All right? Now, probably best managed by your primary care physician because there are regular labs you need to check, and there's some surveillance when it comes to GI side effects. So that's probably best managed by your primary care physician. Cortisone, again, a useful adjunct. If we can do a cortisone injection into the shoulder joint and you get 6 months or a year's worth of relief, then that's a wonderful thing. If we do a cortisone injection and you get 2 weeks or 6 weeks worth of relief, we're not doing that again. Okay? And then rotator cuff strengthening. We always need nice, strong rotator cuffs. This is more of a home-based maintenance program, right? 2 or 3 times a week. If you get a flare-up, we can definitely send you to physical therapy for a buff and polish session. Okay. And so this works very, very well. Unfortunately, there are patients who end up needing more interventional treatments. And there's lots of different implants, and there's lots of different subtleties to shoulder replacements. But I'm going to show you the standard shoulder replacement. And shoulder replacement is the same theme as it is in hips and knees, right? You want to replace that worn away cartilage, and you want to replace those deformed parts. So this is a little cartoon showing that. You put this curved glenoid polyethylene piece on the cup, and you can see that's got that nice gentle curve that we talked about. You replace the deformed head with a metal head, and you anchor the metal head with this stem that goes in the middle of the bone. And this is the way it looks on X-ray. So there's the stem in the middle of the bone, anchoring our humeral head. You don't see that polyethylene piece because it's plastic. It's fancy plastic, right? So that's the cartilage. All right? Now I want to finish with a little bit of, just a couple of comments about St. Francis Orthopedic Institute, right? Now, so I'm a Pennsylvania person. I did my training in Philadelphia, both my medical school and residency, and I came out here for a 1-year gig. That was in 2007. And it sounds cliche, but my wife and I didn't have the rental car yet. We weren't out of the airport, and we're like, this place is pretty nice. I don't know what it was about the airport. I go to the airport now, I'm like, this place sucks, right? But maybe it's just because it was so much better than Philadelphia. I don't know. So after that year, I spent 6 months doing shoulder arthroscopy and 6 months doing shoulder replacements, primaries, revisions, and reverses, the whole shoot and match, right? For reasons that are unclear to me after that year, we went to Modesto. I'm sorry. Right, so we went to Modesto, and we were there, I don't know, like 3 days, and we're like, oh my God, what a huge mistake. And it took another 3.5 years to get out of that mess. But at the time, I was at Kaiser, and that experience, the Kaiser experience, was great from a surgical point of view, right? It was a new hospital. They had more patients than they knew what to deal with, and I was operating my face off, right? I was doing all the complicated shoulder stuff down there. And then the Kaiser in San Jose lost their shoulder person, so I inherited all those complicated and revision cases, and it was a wonderful technical experience, right? But it was still Modesto. and B, I really wasn't, I don't want to say bad things about Kaiser, but they really want you to be a technician, right? They don't necessarily want you to take care of people. And that's not the way I saw my career going. So we left Modesto, and I opened an office in San Francisco. And the whole time, I've been taking my operative cases, some of my operative cases to St. Francis, but I didn't have a relationship necessarily with St. Francis, right? You get to meet people, and you talk to people, and they've been talking about sort of developing a shoulder program for a while, and they finally came to me in August, and they said, hey, do you want to come be the medical director of this new shoulder program? And basically, they said, we want you to step up your game and be a better shoulder doctor. And I said, that's fantastic. There's nothing better than being given an opportunity to be better at what you do, right? But I said, to do this, I need you to step up your game, and you need to be a better hospital, right? So we've engaged in that partnership, and there's nothing more exciting than when you're given that opportunity, okay? So that's what being a medical director of shoulder surgery at the Orthopedic Institute is all about. That was a shameless plug, by the way. I don't know if you noticed that, right? All right, so 30 minutes ago, I said we had really simple goals, right? We wanted to talk about rotator cuff problems. We wanted to define what that is, and that is this spectrum of disease that develops as a bunch of different factors all coming together, right? Tendinitis, low blood flow, that crazy bone spur thing. And we wanted to talk about treatments, right? And we talked about how physical therapy can affect a biomechanical improvement of the shoulder so that things get better. And then for those patients that don't get better with physical therapy, utilizing minimally invasive techniques so people get better faster. And then we shifted gears and we talked about shoulder arthritis. And what that is basically the wearing away of the tread on one's tires. Right? This person's got steel belts. And again, if we can do simple things to maintain function and relieve pain, then that's fantastic. But if we can't, then there are shoulder replacements that can be done that provide very reliable and durable pain relief and return of function. All right? So hopefully I didn't talk too long and it wasn't too boring, and we've got some questions. There's a special gift for people who have questions, by the way.